bit more question and answer, or should I just, do you want me to go through?
Yeah, I'll do some, I have some quick questions for you here, and then we'll go ahead and then also anything else that you want to add along the way, of course, you're welcome to do. So again, hello everyone, this is Jeff Wuchich with Cure AHC. We have the pleasure today of welcoming Dr. Sujay Kansagra, who is the sleep specialist for our Duke AHC Clinic. And he's going to talk today a little bit about his experience with AHC Champions and some general guidelines to help our champions get the sleep they need to thrive and to improve quality of life, and handle then some chat questions. What we'll do, we're going to keep everyone muted during the time. If you did want to ask a question, go ahead and ask it in the chat at first, or at least let me know that you do have a question, and then we'll save those for the end. And what we'll do is I'll go ahead and unmute and mute people as we need it. That way we'll keep the line nice and clear. We are going to go ahead and record this so that others can listen to it afterwards. I know that there were a lot of people that were interested in being on the call today, but just because of the timing could not. So we do want to make sure that we give them the benefit of a lot of the wisdom that's going to be shared here today. So again, joining me is Dr. Sujay Kansagra of Duke University. Sujay, if you want to introduce yourself a little bit and tell us a little bit about your background and how you got involved with the Duke AHC Clinic, and how many champions you've seen in the time.
Yeah, sure.
That'll be great.
Sure. Well, first of all, yeah. I'm very excited to be here with you. Thanks, Jeff, for having me. I am a pediatric neurologist by training, but I specialize in sleep disorders. I've been here with the Duke faculty for the past 3 years, and essentially did most of my medical training between UNC and Duke over the last decade. I am fortunate enough to work with Dr. Makati, who, as you all probably know, is one of the world's foremost experts in AHC, and he had a particular interest in having me part of the AHC multidisciplinary team here at Duke, because sleep is an aspect of AHC that has not been thoroughly explored at this point. And so I have been seeing patients that come in through our multidisciplinary clinic, and probably have seen upwards of 10 to 15 patients so far. And we are slowly learning more and more about how sleep can impact AHC, and we're exploring a variety of sleep disorders that may occur in children with AHC. And so that's my involvement. I treat a variety of sleep disorders, including insomnia, sleep apnea, restless leg, circadian rhythm problems, narcolepsy, etc., and take particular interest in children that have other central nervous system concerns or disorders, and how sleep impacts them.
Cool. Thank you for sharing that. Tell me a little bit about, based in general, what some of the common things that people wouldn't think about in terms of sleep problems that maybe you've seen in some of our AHC champions, and what to look for, so that
Sure.
where you might start to have some concerns.
Sure. Well, by and large, the main issue that I often see in our AHC children is insomnia of various sorts. There can be difficulty falling asleep. There can be difficulty maintaining sleep. Oftentimes it's a combination of both. So that's by far the most common issue that I will address in clinic. But other things that we will screen for include sleep disordered breathing, like sleep apnea. That's something that we have been routinely sending children for sleep studies, just to get a sense of how frequent sleep apnea is in children with AHC, because that's not something we have a great sense of at this point. Restless leg is not as common, but it's also something that I will sometimes treat for children with AHC. But those are the top three: really insomnia, sleep apnea, and then sometimes restless leg.
Cool.
Now, yeah.
No, go ahead.
Yeah, I was going to say that the basic approach to all this, much like any patient that comes to our clinic, we always start with the basics of sleep, and I'm happy to talk more about that. But it always starts with good sleep hygiene, and we can share some of the basic tips for good sleep hygiene. And then after that foundation is set, then we'll go into more of the sleep scheduling, the routines, the things that might be helping or hurting sleep, looking at some of the behavioral insomnias, which we can also talk more about, and some common tips and techniques that can help a child fall asleep and stay asleep.
Right, those would be great, I think, to go ahead and expand on right now, and then we can talk more about how when somebody comes to the clinic, what that sleep study looks like. But if you would
Sure.
talk a little bit more about some of those tips and strategies that you recommend, that you generally train people on as to kind of get to that baseline before exploring other potential issues.
Absolutely. So I always like to start off with essentially what normal sleep looks like. And one of the main things about normal sleep is understanding what a typical length of sleep is for a child. For children, sleep need varies from child to child, and nobody is the same when it comes to their sleep need. And a lot of your sleep need is genetically based, we feel. But there is a wide range at all the given ages. So when we start off very young, between 0 and 3 months of life, typically the sleep need is between 12 and 18 hours. And that includes over a 24-hour period. And typically we're taking 3 or more naps when we're that young. When we get a little bit older, from 3 months to about 12 months, our need decreases, and it usually is around 14 to 15 hours, and anywhere from 2 to 4 naps. As we get a little bit older, between 1 and 3 years of age, the sleep need is about 12 to 14 hours, and again, there's typically 1 to 2 naps. And then between 3 and 5, our sleep need is between 11 and 13 hours. And this is where we start to typically drop that last nap. Sometimes you're still napping up to 5 years of age, but oftentimes that nap goes away. And then as children continue to get older, again, the sleep need continues to decrease. Between 5 and 10, it's typically 10 to 12 hours of sleep. And between the ages of 10 and 17, it's anywhere between 8.5 to 10 hours. These are the typical ranges, and it's important to understand that sleep is always a range. There's no set number to shoot for, and you always have to evaluate the child in the setting of how they're doing during the day, how easy it is to wake up, whether they seem irritable, tired, having daytime issues, and oftentimes there are children that just have a shorter sleep need than other children, and we have to sometimes take that into account as well. When it comes to tips, I always set the foundation with good sleep hygiene. So everybody talks about sleep hygiene, and what exactly is that? I think of sleep hygiene as essentially any of the behaviors and environmental factors that could help or hurt your sleep. And there are a variety of things that you can do for any child, and really even for adults out there. This is typically good advice. And it all starts, the first step is developing a good nighttime routine. And a nighttime routine usually takes anywhere from 20 to 30 minutes. It incorporates multiple 3, 4, or more activities that are calm, quiet, and relaxing, that are done the exact same way every single night leading up to sleep. And I always tell folks that, if a nighttime shower or bath helps calm down the child, that's a great part to put into the routine. If you find that a shower or taking a bath actually activates the child gets more excited, then I usually say, well, save that for the morning. The routine, other good things to include in a routine, brushing teeth, changing into pajamas, having a nighttime story, all those things are a good part of the nighttime routine. And the routine should end with the child in bed, and you can have your last part of the routine while the child is in bed, such as a nighttime story. It's always a great idea to try to leave the room prior to the child actually falling asleep. And we can talk more about why that's so important later, but a good nighttime routine ends with the child still awake, in bed, feeling drowsy, and then the parents leaving the room. The second good part to sleep hygiene is avoiding light. So everybody says, oh, try to avoid TVs and laptops and tablets prior to bed. And the reason for that is because our brains don't really distinguish artificial light from sunlight. Anytime we see something that's bright, our brain interprets that as the sun still being out and that it's still being daytime. And it shuts down our brain's own natural sleep-inducing hormone, melatonin. And so if you have even a smartphone up to your face late at nighttime or you're watching television, that bright light will make it harder to sleep because it shuts down our natural brain chemicals that help promote sleep. So I usually say trying to avoid electronics for half an hour to up to an hour prior to bed is usually a good standard. And the last bit is to avoid substances that can disrupt sleep. So the main one for children being caffeine. Even caffeine that's consumed in the morning, some of it, believe it or not, is still in your system at nighttime when you're trying to fall asleep. And that can inhibit deep sleep. It can cause more frequent arousals at nighttime. So it's always a good idea to try to avoid caffeine altogether in children. Now, if you pair those 3 steps with other simple rules, such as trying to keep the room somewhat on the cool side, most people say between 68 and 72 degrees is ideal room temperature, avoiding any sleep disruptors like noises, pets, etc. All that is also important to sleep hygiene. But those are the 3 main steps for good sleep hygiene.
Gotcha. So once we have those established and we still have issues, tell us a little bit about how the sleep study goes. and how you interpret the results from there, and
Sure.
again, how that whole process plays out, so people would know what to expect before coming
Sure.
to a sleep study.
Sure. Well, we've routinely been doing sleep studies in patients with AHC. It's not by any means standard of care at this point, but we're looking to see how frequently children with AHC might have problems like sleep apnea. The main setup is that we have lots and lots of wires that a child is hooked up to. Nothing hurts, but it's a little bit different than a typical night of sleep. We have wires that are pasted on the head for an EEG, which most families are very familiar with. It's not a full EEG. It's usually a smaller version of a full EEG, so not as many leads that go on the head. There are wires that go right around the mouth and the nose that detect how much the child is breathing. And then there are also EKG wires that go on the chest to look at the heart rate. There's a wire on the finger for oxygen measurements. There are wires that are on the legs to see if a child is having frequent movements. So there are wires essentially everywhere. And then we ask the child to go to sleep, which is, you would say, well, that's going to be hard to do. But most children end up doing fairly well. And really what we're looking for is not a perfect night of sleep. We're just looking to capture as many hours as possible to get a sense of how well the child is breathing during the night. We know that children that have any sort of central nervous system issues or disorders can be at risk of sleep apnea for a variety of reasons. The two main things we're looking for are, one, blockages in breathing. So children that snore, that's often a sign that they may be at risk of having sleep apnea because their airways are a little bit more narrow when we fall asleep. About 1/4 of children across the board that snore actually have sleep apnea. And what happens with sleep apnea is that your airway kind of collapses or narrows down so much that your lungs aren't getting enough air, and so your body's not getting enough oxygen. And that causes you to wake up frequently at night. And it might not be full awakenings. There sometimes is very small awakenings, but it's enough to disrupt your sleep and cause you to not feel great the next day. And it can also have impact on your heart health and your blood pressure, all sorts of stuff. And so that's really what we're screening for with a sleep study, looking for problems with breathing. The second type of breathing issue, apart from blockages, are what we call central apneas, in which the brain, for some reason, just doesn't send a signal to your lungs to take a breath. And again, if you have any sort of disorder that affects the central nervous system, we think that you're at higher risk of having central sleep apneas. And that can also cause your oxygen levels to fluctuate and drop throughout the night, and may also disrupt sleep. So those are the two main things we're looking for. The other information that we get is how frequently a child is moving around and whether they have concerns for very restless sleep, something that we call periodic limb movements of sleep, where the legs are constantly kicking throughout the night. Mm-hmm. And that can lead us to have increased concern about restless leg syndrome. So this is all information that we can get from a sleep study. If a child also has frequent seizure activity, sometimes the physicians order the sleep study with a full EEG to get a sense of whether or not the child is having seizures at night. That's rare. We don't often have to do that, but that's also that can be a
Okay, unfortunately I lost you there for just a second.
Sorry, can you hear me?
Yes, I can hear you now.
Okay.
If you'll repeat just like the last sentence that you said, that'd be great.
Yeah, so I said we're also looking for limb movements at nighttime to see if a child is particularly restless at night. And if we see evidence of limb movements, frequent movements of the leg, that'll sometimes make us think about restless leg syndrome. It's not diagnostic, but it helps us ask the right questions when the child comes into clinic.
Gotcha. Excellent. So I know there were a couple other things you wanted to talk about after that. Once you've completed the sleep study and maybe you've diagnosed some of these things, what are some of the courses of treatments that you recommend, and some of the things that are done to try and improve these particular issues that you find?
Sure. Well, if we do end up finding sleep apnea, if it's obstructive sleep apnea, we think there's a blockage in the upper airway while the child sleeps throughout the night. The typical method for young children is to have them evaluated by an ear, nose, and throat doctor, and they will look to see if the child has large tonsils. They'll look to see if they're at risk of having large adenoids, which sit kind of in the back of the nose. And those tissues can grow typically between the ages of 2 and 8. They tend to be a lot larger and can cause blockages. So oftentimes, if you have significant obstructive sleep apnea, the best treatment of choice might be surgery to have your tonsils and adenoids removed. Other options include CPAP. This is a mask that you'd wear at nighttime that essentially blows normal air, but just blows it at a little bit of a pressure. And that pressure helps just keep the airway popped open while you breathe. That can be challenging for children to wear. It really depends on how tolerant families think the child will be with that sort of a device. If there's evidence of a restless sleep, the child is frequently kicking and moving, then we'll often ask families whether the child, if the child is verbal enough to kind of express what's going on in their legs, we'll ask them, hey, do you feel abnormal feelings in your legs? Do they hurt? Do they bother you? Sometimes we rely on parents' reports that the child seems irritable or uncomfortable at night and wants to keep moving their legs around. And if we are concerned that the child has restless leg syndrome, we'll often check iron levels, ferritin levels, what it's called, to see if they're low on their iron and consider supplementing them. The main issue that we often treat that we don't really even need a sleep study for is the insomnia issue, which is that children have difficulty falling and staying asleep. And the main things that I screen for are, one, whether the child has sleep onset associations, and we'll talk about that, and two, whether there are limit setting issues. So sleep onset association is essentially that a child has learned to fall asleep in certain circumstances that are not conducive to a good full night of sleep. And by that I mean the child has gotten used to either, let's say, having a parent right next to them, laying down next to them, or rocking them to sleep, or feeding them to help them fall asleep, or even things like watching TV to fall asleep. All of those, the child will learn, I need this in my environment in order for me to kind of shut down my brain. And so they learn to rely on those kind of external sources to help their brains calm down. And adults have the same problem as well. So, adults that say I have to have, the TV on, for this amount of time before I start feeling sleepy, that's also a sleep association. And what we do in clinic is teach parents to slowly try to have children learn to fall asleep on their own without the need for these associations. And it can be a long process. Sometimes be a short process, and there's a variety of ways to do it. But the key is eventually to remove any sort of caregiver involvement at the time that the child is going from wake to sleep, so that they learn to end up falling asleep on their own. That becomes important because as the night goes on, all children and all adults, every human being, wakes up multiple times at night, typically after a full sleep cycle, which lasts anywhere from 60 to 90 minutes. It's a normal part of sleep, and what happens is when you wake up in the middle of the night, if the environment is now different than the environment you fell asleep in, it can be very difficult to go back to sleep unless the same things that were present when you first fell asleep are then put back into the equation. So for children that have to be held, let's say, by parents to fall asleep and they're getting rocked every night to sleep, when they fall asleep, parents put them down to bed, they leave the room, then the child wakes up 90 minutes later, look around, they say, hey, wait a minute, I'm not being rocked anymore. This is not what I like. And then they will usually cry or call out for parents until that same intervention is put back in place. A child that learns to fall asleep on their own without these interventions will wake up in the middle of the night and ideally kind of look around for a second, thinking, hey, not much has changed, and then go right back to sleep. That's the ideal. So that's sleep associations, and we have to work hard to try to get children to fall asleep kind of on their own without interventions. The second main issue is limit setting, which can also be very challenging. This is for the older toddler or school-age child that has to have make certain demands at nighttime, such as, hey, I'm not ready for bed, I need to watch a little bit more TV, I need one more hug, I need another glass of water, I have to go to the bathroom. This is clearly a child's way of testing limits and saying, hey, I'm not going to go to sleep until I get this, and this. That's really kind of delaying tactics. And usually the answer to that is having families set firm limits, and if a child is doing this, and returning them to bed every time they attempt to leave, if the child continues to leave the room or tries to leave the room, and essentially establishing firm limits for the child. If a child is amenable to a reward system, some children, if they are old enough and understand enough that, hey, if I stay in my room, I get a sticker at the end of the day, or I get a little check mark on a calendar that's on the door, that can also be helpful. So lots of positive reinforcement. For children that have frequent awakenings, despite these issues being corrected, they just wake up all the time, even though the parents have great sleep hygiene in place, have gotten rid of any sleep associations, have set good limits for the child, then sometimes for children with AHC, we also turn to medications. It's not my go-to, but sometimes it can be necessary. And we talk about things like melatonin. We talk about things like clonidine if a child is particularly hyperactive. We talk about medications like Neurontin, all of which can help facilitate sleep. But that's definitely on an individualized basis, depending on the family and the child's needs.
Excellent. One of the other things I know is that a lot of times there are certain medications that can affect other medications that can affect sleep. Have you seen any of those in AHC, and
Yeah,
what
so
would you recommend in those areas?
yeah, it's typically the anti-seizure medications that many of the children with AHC have, and there are some seizure medications that can help or hurt sleep. Lamictal is a medication that is often used, which can help with sleep. It can make you sleepy, but sometimes we will see insomnia with Lamictal. Medications like Onfi, Valium, Klonopin are all actually good medications to help induce sleep. Oftentimes, if children get them, they start feeling sleepy, and it's much easier to fall asleep. However, some of the medications that work on the benzodiazepine receptor, like Valium, like Onfi, they may actually prevent children from getting into the deeper stages of sleep. And so we always try to limit the benzodiazepine medications, in particular Valium and Klonopin. Onfi, we don't have that much great data on, but definitely Valium and Klonopin can sometimes prevent children from getting into the deeper stages of sleep, even though it might help them initially fall asleep. Now, if a child is doing well otherwise and needs it for seizure control, obviously that's the priority. But those medications we try to avoid, especially if they're used just to induce sleep. I'd rather use some other better medications to get children to fall asleep.
Excellent. And I know you actually published a booklet a while back on the subject of children, helping children fall asleep. You want to talk a little bit more about that and
Sure.
some of the highlights from that and how that might be helpful, and where people might be able to find that?
Yeah, absolutely. The book is called My Child Won't Sleep, and it's literally a book that you could review in 1 hour, and it discusses all of the main behavioral causes of difficulty falling asleep in children from infancy all the way up to teenagers. And each section covers a specific age range, and it goes through techniques that you can use at home. And again, these are typically techniques that address just the behavioral causes of insomnia, which I think is always a good kind of foundation to start with. For children with AHC, I usually recommend using these techniques, but also discussing them with your AHC physician to make sure that they are comfortable with trying them, especially when it comes to some of the medications, even like melatonin. You always want to make sure that you're talking to your physician about using those types of medicines, because they can potentially interfere with other medicines, and really there's some data that it might interfere with seizure control. Limited data, but there's some data. And so it divides it up based on the age range. It actually talks about sleep associations, similar to what we talked about. It goes through a variety of techniques you can use to get rid of sleep associations. It talks about limit setting and the techniques you can use there. It talks about circadian rhythm problems, where children naturally have delayed their bedtime and wake time. These are children that like to go to bed very late and then sleep in. And that's often a problem in the older child, the teenagers. And we talk about ways to help move their schedule forward as well. It's available. The book's available on Amazon through Kindle, and that's the best place to find it. And the goal was, in 1 hour, you can read through the whole book and really get a good sense of the typical behavioral causes of difficulty falling and staying asleep.
Excellent. And I can personally say that we have found that helpful with Matthew. So thank you for putting that together and making that available to the general public. Was there anything else, Sujay, that you wanted to add in here that we haven't covered so far? Because I've kind of run through some of the ideas that I had in mind to share with our audience.
Sure. The main thing to keep in mind, with children with AHC, the amount of involvement and severity of the AHC varies quite a bit, and so I always recommend trying to work closely with your neurologist or sleep specialist if sleep is an issue, to tailor the approach to your particular child. There are some things that apply to everyone, such as sleep hygiene and some of the the routines and things we talked about. But when it comes to children that have seizures, other medical issues going on, reflux, allergies, all that also needs to be addressed and can definitely impact sleep. So I recommend working closely with your physician to find a good treatment approach for your child.
Right. I know one of the questions that came in here, and you may not have a good answer for this, but we know from experience that for AHC Champions, when they're in an episode and they go to sleep, when they wake up, generally speaking, the episode has resolved. Is there any theories as to why that might be, And also, if is there any recommendation to trying to help induce a nap, even in older children, if they're having an AHC episode, if it's practical? That's a question that's come in that maybe we would want to go ahead and address here.
Yeah, that's a great question. So we don't really understand why sleep itself will abort a typical AHC episode of hemiplegia or double hemiplegia. You could conjecture that some of the let's say the ATP exchanger channel, for some reason when you're asleep, has a chance to relax and maybe is not as dysfunctional, and that gives your brain a chance to relax and get over an episode. And we know that some children, after they wake up, episode's gone, but a few minutes later, sometimes episode starts up again. And so it could just be that the area that's dysfunctional has a chance to kind of relax and quiet down while we're asleep, and then when we're awake, that area is taxed once again, and then those brain cells are not working as well as they should. So that's the theory. We don't really know for sure, and that's something that we continue to try to explore. When it comes to inducing sleep, it's difficult because there aren't any great medications that will quickly help a child fall asleep. Now, certainly if it's around time for a child to take medications and there's a safe way to administer their seizure medications around the time of an episode, then that can definitely help. Obviously, if, and by safe method, I mean if a child does have a G-tube or has swallowing function is still intact during an episode, then that's something to consider. Medications like Benadryl I usually avoid because they can actually increase your tendency to have seizures. So children that have a history of epilepsy, I avoid Benadryl. So there's not too many great medications. Now, clonidine is something that I've used in the past in children. Neurontin is something that I've also used. These are options, but they do require a prescription. But the main thing is making sure the child is safe from a swallowing standpoint during these episodes. And so it's hard to administer some of these medications if the child is having a severe spell and get them in safely. But your question is definitely a good one. We're still exploring why sleep seems to help, with the goal of being able to find a medication that has similar effects to sleep without necessarily making the child sleepy. So if we can find a medication that can help that part of the brain recover and relax during an episode, hopefully we can find a way to abort the spells without necessarily just inducing sleep for the child.
Thank you. I did want to go ahead and open it. We do have several people on the call right now. If somebody does want to go ahead and indicate if they have any questions presently. I know one that we had previously also in here that one of our parents reports that it seems that their child never really fully falls asleep. They have a very strong startle reflex. And so that the slightest noise or anything will suddenly wake them up. And they seem that as soon as they fall asleep, they startle and they wake back up. I mean, if you want to address something, is that something you've seen? Is that something of concern? That might be something here to go ahead and cover.
Sure. Yeah, I do see it. I won't say that this is something that I've seen in particular with children with AHC, but it's something that I see, frequently in my clinic where parents say the child is just very light sleeper, and anything that, any small noise will wake the child up. In that situation, I usually, I do one of two things. One, sometimes the environment at baseline is a little bit just too quiet all the time, and so the child hasn't really gotten used to having a little bit of background noise. And so I usually tell families when the child is, first learning to kind of sleep longer stretches, you don't have to keep the house, completely quiet. It's okay to kind of go about your daily activities. So there is some kind of getting adjusted to having background noise. The other option, and probably the better option for children with AHC, is having something in the room that can help filter out some of the background noise, to have a constant background noise with something like a white noise machine or a box fan, something that's constantly running at a constant noise that will help screen out some of these sudden, abrupt changes in noise. And it's those abrupt changes where it goes from complete quiet to sudden, somebody slams the door or the phone goes off. Those abrupt changes are what end up, causing the startling and the light sleep. That constant background noise, children get adjusted to, fall asleep fine, and then it dampens out some of those abrupt fluctuations in the background noise. I don't recommend using things like radios or televisions where the noise itself is fluctuating all the time. Rather, a white noise machine or a box fan, something with constant background noise, is usually a good approach.
Got it. We do have a question here about whether the multidisciplinary team is planning to study and publish about sleep problems in the AHC.
Yes, we are. We've been looking into it. We have a number of children that have undergone sleep studies, and that is the plan.
Excellent, excellent. Oh, we will make sure that we keep our audience abreast of that as that develops.
Great.
Were there any other questions from our audience? Would everyone want a chance here to either chime in or chat in or raise their hand?
Jeff, this is Brittany.
Hey, Brittany.
Janice mom. Hi. Quick question. He is sometimes up, down, up, down, up, down. What's up with that?
Sorry, you're saying your child is up, down frequently throughout the night?
Yeah. It's like he will get up sometimes 25 times a night.
Wow. Yeah, if a child is getting up more frequently than every hour to an hour and a half, which is a typical sleep cycle, then I worry about other things that can be disrupting sleep. So that's usually when I'll start delving into more of the other medical problems, such as reflux, looking at signs of pain or discomfort, increased muscle tone, allergies, and the signs of sleep apnea. All of these things can potentially cause very frequent awakenings throughout the night. Usually children that have just a behavioral cause of difficulty sleeping, it's usually, we're talking 4 or 5, maybe 6 times a night. It's usually not, 20, 25 times a night. So if it's that frequent, I usually recommend a medical eval from a sleep specialist just to screen for other underlying disorders, considering a sleep study if the child snores, and then still putting in the behavioral approaches and the sleep hygiene, but really looking for other underlying triggers.
Thank you. Yeah, we know he has both apnea and severe reflux, so you hit the nail on the head with that.
Okay.
Excellent.
Well, I hope those are. Yeah, I hope both of those get better. He's being treated for those.
Thank you.
And Sujay, we do have another question about foods, maybe to avoid besides caffeine or other foods, or when to eat it, if the timing of eating affects the potential for getting to sleep or not.
Yeah, great question. So many people put emphasis on sugar and what sugar does at nighttime, and usually it's not necessarily the sugar that ends up keeping children awake and hyper. It's usually caffeine that's also accompanies many of the beverages that have sugar in them. And so there aren't many foods, from my standpoint, that I exclude so long as they don't have caffeine. And so, chocolates and sodas, iced tea, coffee, obviously. But chocolate can be a big one, especially dark chocolate that ends up having a lot more caffeine than one might think. But other foods overall, I'm fine with. But the timing is also important. As you mentioned, I like to have children, if they can be on a great eating schedule, that also influences their sleep schedule, because it actually influences their natural body clock, their circadian rhythm. So eating at regular intervals during the day can help establish your body's own natural circadian rhythm, and that can also help you fall and stay asleep at the right times. Eating too late can sometimes cause you to throw off that natural circadian rhythm. And so, yeah, having set meals is great. I usually recommend avoiding food at nighttime. So after it's 4 to 6 months of age, depending on the child, you don't necessarily need nighttime feeds. And so I often work with families on slowly decreasing nighttime feeding, as long as there isn't any other medical indication for which they need frequent, nighttime feeds. And so those calories can oftentimes elevate blood sugar for prolonged periods throughout the night, and so I usually, recommend avoiding any sort of intake during the night. And that also can cause more, frequent and episodes of having to get up and use the bathroom, further disrupting sleep. So I usually say dinner at least an hour or 2 prior to bedtime is a good idea, with limited fluids and food after nighttime, except for maybe a small nighttime snack before they go to bed.
Excellent. Thank you for that. Any other questions from everyone? Because we are coming up near the end of our time here together. If not, I do want to thank you, Sujay, for your time here today. This has been very informative. We greatly appreciate the time and effort you're putting into the multidisciplinary team at Duke for AHC, and the research you're helping to facilitate, and the treatment plans that you're putting together for all our kids so that we improve quality of life. Because we know that, of course, not getting good sleep is impactful not only for the child but also for the family, also for the parent. And so we're not as best advocates for our kids if we're not getting the sleep. And of course, if our kids are not getting sleep, we're not getting sleep, and everyone's suffering. So we know that helping our champions get the sleep they need will ultimately improve everybody's life. So that's why we were very much appreciative of your time here today. And of course, we're going to end with a small disclaimer that, of course, all this is provided for informational purposes only. This is not intended to diagnose or treat any diseases, and please consult a physician prior to implementing anything that you've heard spoken about today. Again, provided as information only. But Sujay, thank you very much for your time. Thank you, everyone, for your questions and for joining in today. And again, this is something that will be recorded, has been recorded, and will be available online through our website, through our YouTube library, and then ultimately the AHC International Media Library. So again, thank you, everyone, and we'll go ahead and conclude for today.
Thank you very much, Jeff. I appreciate it.
Thank you. Have a great day.
All right.
Bye now.